Thanks for coming, guys, to our May GETUP conference. I'm going to present our first case. Maybe I'll just get you, Race, and your team there. Tell me what you think. So it's a young male person, young male who's gone to a health food shop, and not sure why, but they wanted probably constipated, but they bought an enema from this health food shop. Now this enema contains 35% hydrogen peroxide, and he's used up to 70 mils of a 3.5% preparation. Now, from that kind of risk assessment, well, what's a risk assessment, I suppose? I can ask these guys what your risk assessment would be, and what you think would happen.
Well, that's sure to give you gas.
Okay.
And corrosive. Yeah.
Okay.
You'll change
Sorry, I couldn't resist.
All right, so I guess for starts, what do we think?
I've never heard of an enema with this, but we do get cases of oral hydrogen peroxide. You said it was 30%?
35%, yeah.
Oh, 35%. Yeah, that's a very concentrated amount. You know, typically the retail formulations of these have about 3%, 1 to 3%. And you could buy stuff on the internet and I guess at other shops that have much more higher concentrations. And I think on the internet, people believe or, you know, read that you can get really high doses of oxygen. So people are trying to extract oxygen from this hydrogen peroxide. And that's why it's kind of taken on a lot of popularity in the US as like an alternative cure for a lot of different things. And people drink this stuff and or maybe accidentally ingest it and get into trouble with you know, too much oxygen, as it were, and then it causes air embolism.
Yeah, that's right. So I heard, besides the oxygen liberation, we heard corrosive injury. So you said corrosive injury. So he's had some diarrhea overnight. And he rang the poison center today because he's had some rectal bleeding and some abdominal pain as well. And he presents to the hospital with abdominal pain, but the bleeding has stopped. And they're assessing if there's local damage. So that's when the call was put through to us. And we advised that you could get mucosal injury, bleeding, and perforation. What other investigations, I suppose? My question just to the group, what do you do? Anything? Just watch them?
I would get it.
Right?
Is otherwise well?
Otherwise well.
Yeah.
And how long are we going to post?
Just overnight. Yeah. What did you say, Race? What would you do?
Well, I would get some imaging. There's some striking pictures of when people swallow hydrogen peroxide. The air gets up into the portal system and it causes pneumobilia, and it can cause you know, just air bubbles in the intestinal wall, which the name for that is, I think, pneumatosis intestinalis, and you know, ultimately necrosis, which is, you know, what the feared complication is.
Yeah.
Then you know, if this person has like a patent foraminovalia or some other shunt, he's actually at risk of getting systemic emboli into you know, his brain, basically, and causing embolic stroke or even coronary complications. So just wherever these gas emboli end up, it can just cause necrosis and ischemia. So, you know, I would get some imaging just to see where these bubbles are going. Yeah,
that's right. So there have been case reports of gas emboli and portal circulation previously, and intraperitoneal gas and perforation. So he had a CT abdomen, which was normal, and it was admitted overnight for observation, which was otherwise okay. But just on the discussion kind of point, would anyone scope this patient, I suppose?
Colonoscopy.
Colonoscopy, yes.
The same concept as any corrosion. So if you put a scope in, there's put them at risk of perforation of their fragile tissue.
I'm not sure about the red one.
Why would you do it? Because you know,
I'm just asking the
No.
question, but it's a corrosive injury, I suppose. Would you just?
Yeah, I've come to the same sort of discussion about oral corrosives. Is now that CT is so good, now that our imaging is so good, do we really need to be scoping all these corrosive injuries either from above or below? I mean, like Zeph says, what are you going to do differently? What do you want to know that you're not going to find on CT? It's not like you can go in and fix anything with a scope. You're just going to be able to see damage, and then the treatment will still be the same, which is, treat the patient and how sick they are.
Mm-hmm.
And if you don't see a perforation on CT scan, what is a scope going to show you, I guess?
Yeah. And given that the CT was normal, I don't think there was any big rush to need to scope him.
are there steroids? Does that help corrosion?
Well, that's the good question, because maybe not. I don't have an answer for the lower GI tract, but for the upper GI tract, there's been one RCT, probably about 50 patients in children, that's shown that some IV methylpred has decreased. People who have had steroids has decreased the rate of grade 3 lesions. So there's probably there's probably 3 groups really. The ones who are going to do well without no steroids and are just going to heal. I'm just talking about the upper GI tract now. There's the middle group, but steroids may be helpful, and there's obviously the grade 4 lesions where you probably can't do anything, and the necrosis, so the steroids are probably never going to help. So, potentially a scope in the upper GI people may help determine, or you could just give steroids. I mean, I think the downside is going to be pretty low.
Well, I think the downsides with steroids are the infectious complications, because
Correct.
even with
Correct. Yeah.
RCT in kids, they gave high doses of steroids, and those kids ended up getting things like brain abscesses and a lot of other weird infections because they were so immunocompromised. And I think that is a real risk in this guy who basically has a very leaky gut at this point, and he's going to translocate a lot of bacteria. And it's like, I think steroids is definitely something you have to think about and consider cautiously.
Yeah.
I mean, I think the reason that they give steroids for the esophageal lesions is to prevent strictures down the line. And it's like, do you even worry about stricture formation in the colon? It's like, is that even a complication that you have to worry about? So
I've never come across it, because I guess it's not that common. I think most of these people just heal up by themselves without any complications. But I never heard of strictures in the colon, let's say.
I think the less we do, the better.
Yeah, probably. Have you hyperbaric any of these people?
yes. Well, I've never had an enema one, but I had a lady who took 20%. Here, actually, let me turn the video on because I got to share this picture with you guys. I still have the bottle. This lady had a heart attack. Her brother-in-law said, "You had a heart attack. Your heart needs more oxygen. Drink some hydrogen peroxide." Let me give you this 30. Seriously, let me give you this 30%, 35% food grade hydrogen peroxide. This is the bottle, but remember to dilute it. This lady has had a heart attack. She's probably got Alzheimer's. She's like 70 years old, and she forgot to dilute it 1 to 10. So she just drank this, and this is actually a bottle of Coors that the guy. This is the actual bottle with the actual paper. This is a Coors beer bottle that the guy emptied out and gave her 35% food grade hydrogen peroxide, and she drank a few gulpfuls. And she got a bad esophagitis. She actually got some pancreatitis. She didn't have pneumobilia, but then she embolized enough to where she had actually some bubbles in her head.
Yeah.
Headache, severe nausea, vomiting. She was actually an airhead for a while. And we decided that because she actually had evidence of emboli in her brain, that we were gonna press her with hyperbaric oxygen. And so that's what we did. We did 2 sessions. It cleared up it made her headache feel better. And maybe it probably made her heart feel better too, just to get all that hyperbaric oxygen. So she finally got the high dose oxygen that she wanted.
Yeah.
And she stayed in the hospital for, I think, about 3 days. And then she had a pretty good outcome. But that's where I started learning all about all these health practices with the high dose hydrogen peroxide. So that's my one and only case of the high grade, the food grade hydrogen peroxide, 35%. And we ended up doing HBO on her.
Just a
So I think
question.
if, you know, if there's bubbles in the brain, I would definitely put them. I think
Yeah.
with new mobilia and with some of this other stuff, I'm not sure that it's going to help. Probably because the damage is already done. But you know, if you have a threat of emboli in the brain or in the heart, I think I would try to shrink those bubbles as small as possible by putting them in the hyperbaric chamber.
Sorry, I've got an image here that this is colitis from hydrogen peroxide enemas.
That is not good.
Wow, look at that. And that is that from this patient?
No, not this patient. I think it's
This is a case in the literature. A 61-year-old abdominal pain. Symptoms began immediately after the application of a self-prepared enema solution of 6 tablespoons over the counter 35% hydrogen peroxide mixed with 1/4 of distilled water. They had been performing this once a month for several months to cleanse himself.
interesting.
Oh, I'm gonna stop doing it.
Good to know.
Just a question, Race, just on your treatment. How long did you hyperbaric them for, and how long before you decided to hyperbaric them?
You know, I just, this was about 5 years ago when there really weren't a lot of these case reports coming out yet, and I just saw a couple of case reports about doing it, and I actually called our hyperbaric consultants, and they have dive tables. Unfortunately, I don't know the details, but I know that she got 2 sessions, and that she felt better in terms of her headache, which was really our best clinical measure at that point of how she was going to do. But I don't remember exactly how long they dived her for. I think they just basically did her like the carbon monoxide dive tables, where they did like 30-minute sessions or whatnot. I think they went down to 2 atmospheres with her. But it was very similar. You know, we said just treat this like a carbon monoxide because we really didn't have that much data to go on. And, you know, we just wanted to give her more time, I guess, to resorb those oxygen bubbles.
Yeah, that was interesting. Nice, thanks for sharing your case.
Yeah.
Did you have anything to add, Anne-Marie, about the hyperbaric?
You don't want me to start talking about dive tables.
Okay. Our registrar at the moment is interested in hyperbaric medicine, so that's all right. Why don't we? Do you want to talk about your case first before I go on to the next one, or you had something?
I'll talk about it. So I actually have a double case, and I'll call this the Chemical Brothers, and you'll find out why. All right, so have you guys ever heard of the Coachella Valley Music and Arts Festival? This is a famous festival that happens in the desert east of Los Angeles, 2 hours east of Los Angeles. And it's called Coachella. A lot of young people show up there. I actually went when I was a Tox fellow when I was living in San Diego. This is 2 patients that showed up to the community hospital that's like right at the Coachella Valley. You know, this is like their community hospital basically. And both patients had taken multiple substances. Patient number 1 took mushrooms, LSD, synthetic cannabinoids, and alcohol, as best as we can tell. Patient number 2 took THC, like regular old THC, ecstasy, and alcohol. Temperature on patient number 1, 109 degrees Fahrenheit. Temperature on patient number 2, 107 degrees Fahrenheit. Seizures, rhabdo, liver failure in both of them. They both got intubated, and this is a community hospital. It has an ICU, but it's really not a very super specialist hospital. They're both intubated, they're both sedated, and they're both getting cooling treatments. It's unclear exactly what cooling treatments they got. And then they're transferred to UCLA, which is sort of the tertiary care liver transplant center for further care. In terms of the liver injury, patient number 1, AST, ALT is in the 3000s with an INR of 1.4. Patient number 2, a little bit less ill. AST, ALT is 1500, 700. INR is also 1.4, and not a lot of other labs given. So I guess the questions that they had for us at the Poison Center, the liver transplant service is asking this, and is there anything specific that we need to do to treat these guys that are very hyperthermic? And then I guess a bigger follow-up question that I had was, you know, how do we prevent this? I mean, this is a festival that we know happens every spring.
Yeah.
This is a festival where we could predictably expect people to be doing drugs. And so what's the role of poison control centers to interface with music festivals where we know drugs are going to happen? You know, how much of a preventative or educational role should poison centers be playing around these music venues? So I just wanted to share these cases because I thought they were so interesting. I mean, I was anticipating that we would get something from these festivals, but I'm not really sure what we at the Poison Center are supposed to be doing in terms of, you know, what's our specific role whenever these cases come up. So do you guys have those sorts of festivals? And, you know, specifically with these guys, 109, 107 Fahrenheit.
So just from the medical, yes, we do have these festivals, Grace, and even Melbourne where we are, and it's also common to get these hypothermic patients. They might not necessarily be in the hospital or be called to the Poison Center, but a lot of hospitals around the periphery of these festivals are quite au fait in dealing with these kind of problems. And I guess in this case, you know, I can ask the question, what we think about cooling, I suppose, is the main priority in these patients. So I'm assuming these patients were intubated and paralyzed as soon as they got into hospital.
Yes, that's correct.
Yeah.
Yes.
And did their temperatures come down after they were intubated and paralyzed?
Yeah, they did. They came down. By the next day, their temperatures were within normal or even low, 36 to 37 Celsius. So they responded to the cooling measures. The other question was, you know, is there something specific that you do about the hepatotoxicity? Would anyone give acetylcysteine? No acetaminophen has been ingested, but how do you feel about giving NAC in a patient with liver failure that's not related to acetaminophen?
Well, my question, Race, would be what was their CKs? Because the AST and ALT could be representative of rhabdomyolysis, and it's actually a muscle thing rather than a liver problem. So 1 out of 1.4 is not particularly impressive. So I wouldn't necessarily say they got liver failure. So do you know what their CKs were?
I know it was elevated. That's a good point. So yeah, they did have rhabdomyolysis.
Well, it could be because it's hard to know whether it's an ischemic hepatitis or whether it's the enzymes that from the muscles rather than from the liver.
If it's an ALT of 3,000.
I know that happens with AST. Does that happen with ALT also? I mean,
Yeah, it does.
have you guys seen that? Both AST and ALT going?
Yeah. But if it's ALT and AST of 3,000, usually, or just a rhabdo, the CK is usually around the 100,000 mark to be related to that. So there probably is a degree of multi-organ failure here, I imagine. If the CK is that high. And I'm assuming the kidney might be some mild kidney injury as well.
And in terms of the NAC, you know, our unit here in the intensive care unit, anyone with a liver problem gets NAC. It's like a tonic. So even in the non-acetaminophen-induced hepatotoxicity, NAC is used for its, I guess, improved oxygen kinetics, free radical scavenging properties, you know, replenishment of glutathione anyway. So it's sort of sprayed about pretty liberally.
In answer to your question about Poison Center's involvement, there's a lot to think about there. Part of it is, did they take what they said they took? And is this an idiosyncratic pharmacogenomic problem with these two individuals that they couldn't metabolize, or they just burnt up with their MDMA? Or did they actually take another synthetic amphetamine type substance which is more prone to hypothermia and problems? So in terms of harm reduction, the whole concept of pill testing, and whether there's evidence that young people know what's in their pills, they may not take it, may be helpful. It's difficult to know. Did you have any clue of whether they took what they said they took?
I don't have a clue, unfortunately. I just don't. I mean, I totally agree with you. I feel like there's so many unknowns here, and how deep down the rabbit hole do you go? Do you test their blood, which means that you have to have access to an analytical lab, and that lab has to know what they're looking for.
Yeah.
Do you test their genetics to
Now,
answer
that
the
on-site testing, then the Poison Centre could actually promote that and say, you're going to go to a festival, get your pills tested, and that may affect your decision whether you take it. I mean, the European literature, particularly from the Netherlands, shows that young people, if they want to take MDMA and you show that their pill doesn't have MDMA, then some of them won't take it.
Right. And there's actually a website called Dance Safe.
Yeah.
Which is I don't know if it's a nonprofit, but it's some organization that will actually set up booths at these concerts and test pills right there with some kind of an assay that they have to look for adulterants and reassure people that you can figure out what's in your ecstasy before you take it. And they found all kinds of adulterants, from caffeine to bath salts inside, and Liventol and things like this inside these pills. So we know that there's a ton of adulterants in these pills, and
how comprehensive the testing is. Forensic labs up there to find all these odd synthetics, without somebody doing a basic chemical test at a music festival. Those tests are only okay until the next pill comes through. And even then you don't know what's in them.
We're just talking about comprehensiveness of these tests. It might not be as comprehensive.
At the moment, we've got nothing. At the moment, it's the equivalent of going to a bar and just saying the word alcohol, and you get a certain volume and a certain concentration. You've got no idea what you're having, you're just drinking it. And no one would accept that. So, I don't know. There's a bit of work to be done, because young people will take drugs at these festivals, and the war on drugs is, we've lost the war on drugs.
Thanks, Ray. So the case is, did you want to add anything more on that one, or did you? Or you just...
I'm going to call the team in a little bit here and just get the latest, but they seem to both be recovering. One of them has been extubated already, and I don't know about the other one.
Okay.
The worst thing that happened besides the liver injury was that one of them developed cerebral edema and possibly severe global anoxic injury. So, very complicated patients that required them to be at the specialty center. And like I said, it looks like one of them is recovering and the other one's not. I think they ended up starting NAC on these guys anyway, which I can't, that's fine. I'm not gonna argue with that if the team wants to do that. And beyond that, I just thought these were very interesting cases just to share.
No, thanks.
I was just going to ask. Sorry. Hi, my name's Rochelle. I'm one of the emergency registrars. Did you?
Hi.
Hi. I was just wondering that what was the times like from identification of unwellness, and then was there any pre-hospital care, and then time to actually get to the emergency department?
Time to cooling, you're asking?
Yeah, exactly.
Yeah, good question. I don't know how much time was elapsed. I mean, presumably these were witnessed. There were a lot of people around us to this community hospital pretty quickly, and it sounds like the community hospital was very aggressive in treating them. So I don't think there was much of a delay from the time that these illnesses were identified, but
yeah.
I don't have the actual number of hours that it took. How do you guys recommend cooling people down, by the way? Do you have a specific protocol? Do you recommend one thing over another?
I think, Bryce, I mean, it's cooling as much as, if the temperature is around 40 degrees Celsius, I mean, I think that the main thing is to get it done as quick as possible. And benzos, intubation, and paralyzing them is probably one of the quickest ways to do it. And the usual kind of hypothermia treatment, such as ice packs to the groins and axilla, fanning. You know, we don't have an ice bath here as such, but you could put them in an ice bath if you had one of those available as well. Just standard kind of hypothermia management.
Yeah.
To ventilators, given that your whole cardiac output goes through your lungs, do ventilators have a temperature setting? Do you know?
That's a good question. No, I know there's some catheters that do internal cooling now. They'll just cool your IVC.
Well, the other thing is ECMO. I mean, if the patient was in arrest hypothermic, you could put them on ECMO and that could cool them pretty quickly.
But it's a timing thing. You only need to be 42 for half an hour. And
yeah, that's right. So it's a good point Zeph made. It's just that
The nearest thing I could think of was Arctic Sun. The one that's an adhesive.
Yeah, Arctic Sun. I've heard of that.
Yeah, that they usually stick onto your entire body and they just cool you down very, very rapidly. They used to use it quite often when we cool people down for cardiac arrest.
So I think when you look at the ventilators and they have the humidified part, that has a temperature setting on it. So whether you could somehow use that to try to cool.
But humidification is heat.
I know, but whether or not you could somehow manipulate, I don't know, because it's a water bath principle with the ventilator.
Then I know Bob Hoffman in New York has got an ice bath in his ED, and they just dump people in there.
Well, yeah, that's, logistically that's hard to do, to get a ice. And I've heard that that's actually can be counterproductive because it causes so much vasoconstriction at the level of the skin. And, I've heard the best way to do it is just to do misting and fans. And that helps to actually do evaporative cooling efficiently. And if you have a hammock, there's actually a device called a Mecca hammock that they use in Mecca because people overheat during the Hajj pilgrimage, and they actually just have a hammock and a fan, and they've shown that that's very effective.
Yeah. What do you think about the role of dantrolene?
Great question. I don't know if I'd use it. I mean, I've heard that, it's one more kind of muscle relaxer that you can use. And I don't know if there's some pathophysiology in heat stroke that supports using it. Obviously with malignant hyperthermia, you can certainly justify using it, but pathophysiology applies in heat stroke. So, it's not something that comes to my mind immediately. But again, it's benign enough to where I think you could throw it in the mix if you really wanted to, without getting too many, without getting too many criticisms.
I don't know how much more to add to paralysis.
Great. Well, there's no more questions on that case. We'll talk about we'll go to another case.
Sure.
This one was interesting. So I think if I can screen share my screen here, I'll show you. Yeah. Can you see this? Right? What's your picture? Can you see the tree?
Yeah, we can see it.
Great. Any idea? It's okay if you don't. I had no idea either.
I would say it's some kind of a pepper, but it's certainly not oleander. I don't know what those fruits are, but they look very fruity. Pods or buds are.
All right. So I'll give you the story. This man is a 35-year-old man who'd been doing some research on the internet and purchased a lot of the herb containing the plant pretty much to try and get high. And he felt unwell after ingesting the herb and had a lot of involuntary type movements and presented to the emergency department with some mild hallucinations. He was a bit tachycardic, his heart rate was 110. His ECG or EKG showed a QT corrective of 660 and a QT of 470 manually measured. His potassium was 3.1. The ED doctors gave him some benztropine for the involuntary movements, which I don't think did much for it. And then he was given some midazolam to help settle him down. And so then the call came to the boys and said, what do you do? What is this? So if you don't have an idea, just it's ibogaine. It's the ibogaine plant. I'm not sure if you heard. Sorry, no, the plant's not called ibogaine, but the substance is called ibogaine. Don't know if you heard about that.
Yes.
You have?
Yeah.
Right.
We're doing a little case series on this, just from California.
Right.
This is I didn't realize that's what that plant looked like.
Right. Have you had any cases yourself, or you just heard of it? Or?
Yes, I've heard of several through the Poison Center, and I've seen one myself in the ER.
Okay.
And these people, it's usually a very cool story, because these people are usually drug addicts that are trying to detox, or they're experimenting with a new drug. And so these people they're not amateurs, you know, they've been around the block when it comes to drugs. And usually they're heroin addicts, at least in California, that are just trying to find a safe herbal way to detox. And again, this is another one of those internet hoaxes almost, that people are, you know, trying to sell this as a herbal detoxification. Yeah. And there's been a lot of case reports about cardiotoxicity and neurotoxicity. And we've actually seen people have, you know, all kinds of problems, from myoclonic jerking and seizures to cardiac arrest related to ibogaine use.
So ibogaine, just as a background, is used as a psychoactive substance. They're called the Apocynaceae family. And they're used for, they're actually used for African spiritual traditions treatments. I'm assuming it's something like, what's the one they use in South America?
Ayahuasca.
Ayahuasca, yeah, that's right. So similar kind of principles. They use it as a kind of psychoactive treatment or substance to be taken during these rituals. So that's part of its action. But you mentioned as well the kind of fatal kind of cardiac arrhythmias they can have. And I did allude to that with the QT. So there have been case reports of people having prolonged QT due to the action of the potassium channel, I'm assuming. And obviously people with polymorphisms with CYP2D6 that may be more predisposed to getting these fatal kind of arrhythmias.
As in ultra metabolizers or poor metabolizers?
I think the ultra, or whatever increases the concentration, so they poor metabolizers, I would assume.
Is ibogaine the parent molecule the problem, or is its metabolites the problem?
I think ibogaine itself. I have to check to be 100% sure on that. But it's a very, I don't think much is well known about the actual receptors in such, but it seems to act on NMDA, dopamine, serotonin, acetylcholine. So basically, probably not going to do anything for you. I mean, benzodiazepines may be part of the treatment, obviously, in respect to the neurotransmitter problems, but the QT, obviously, potassium and mag replacement. In your patients, did you see any arrhythmias or any QT prolongation rates?
Yeah, I'm pulling up one case here. I can try to share the EKGs. But there was one guy who came in with QT prolongation and then went into torsades.
Right.
and then had to be coded after Ibogaine. And then another guy who, and then he went on to have Bigemini and things like this. Oh yeah, here we go. Oh, this is great. So this is my, here, I'll show you. This is my Ibogaine folder. And this is the case report that I have of strips. And you can see here, he's kind of in Bigemini. I don't know if you guys can see that.
Yeah.
Yeah.
And then he just degenerates into little runs of VTAC, and then he goes into torsades. So this was like the index case that kind of triggered our Ibogaine journey here in California, because we were like, what the hell is this stuff, and where are people getting it? And this guy survived. He walked out of the hospital after being coded and shocked, and resuscitated. And then another guy actually told me, I sat down and talked to this other guy who was like, I was addicted to heroin. My family has spent almost $100,000 trying to detox me from heroin, and nothing is working. So I convinced them to try Ibogaine, and he invited all of his relatives over, and he had an Ibogaine party where basically he got Ibogaine powder from the internet, capsules out of it, and then drank several capsules. And he said he had kind of 3 phases, which was, the first phase was violent retching and vomiting and just feeling terrible. And then he had a phase of just sleeping for like 8 hours. And then after that, he had a phase of like intense clarity where he was like, yeah, I'm definitely detoxed now. So for him, he felt like it worked. And it's a lot like ayahuasca. I mean, that's basically how people describe the ayahuasca trip also, where the first phase of it is just violent GI, and then sort of another altered mental state or whatnot. So it's kind of interesting. That's what these people are seeking. And for some people it does work, I guess, which is why it's not, totally disreputed. And again, there's a lot of internet websites that are promoting this stuff as a detox drug. We've had, like I said, we've had several of these cases, just really like a dozen of these in California that we've been able to find through our Poison Center records. And this is probably the most dramatic one, this torsades, due to the Ibogaine. Unfortunately, we didn't measure levels, so that's going to be a limitation of trying to get this published. I don't even know where to measure levels. This stuff, it doesn't seem to be even though it sounds like cocaine and lidocaine, it doesn't seem to be a sodium channel blocker as far as I can tell. I don't know. Have you read that it is, Anselm, or?
I don't think it's well.
It's not really something you can give bicarb for the way that you can with like cocaine or lidocaine or bupivacaine, even though it sounds like that. This is just a different drug that I don't think we've worked out the pharmacology very well for.
I don't think there's any sodium channel blockade associated with it.
Right.
Anyway.
Yeah, I haven't read that there is.
Is this something?
QT time, I've heard of that, and then the sudden cardiac arrest has also been reported. So.
Out of interest, is this something your FDA might look into, or is there just too many sites on the internet that they can't control this kind of substance?
I think it's already scheduled, but I'm not sure. Yeah, I don't know. Yeah, that's a good question. This one and kratom. There's another drug called kratom, which are kind of they're kind of hand in hand. They're competing for a very similar place in our pharmacopoeia, which is alternative detox, herbal detox drugs. And kratom actually was scheduled for a very short time until a bunch of kratom advocates protested, and the FDA went back on the scheduling, and now it's allowed again. Kratom doesn't seem to be as dangerous, although it can still cause some neurotoxicity, not as much cardiotoxicity. I think Ibogaine is going to be, it's probably going to need to be scheduled if it isn't already.
Great. I've got another case, do you have another case, Race, that you want to talk about, or?
No, you can go ahead.
Okay. So this one was also interesting. So a 55-year-old lady, she took 6 grams of sertraline, 180 grams of metformin, slow release. Yeah. Some ibuprofen, 28 grams, and some linagliptin, 300 milligrams, not that much. And she started vomiting very soon after the injection, an hour or two, and then became a bit slurred in speech. And when she arrived to the hospital, her lactate was already 11, the bicarb of 13, and her pH of 7.1, potassium of 4.7. So I guess, from your risk assessment, maybe I'll ask you, what do you reckon are those, what's going to worry you in that ingestion?
Well, definitely, certainly it's a single agent serotonergic drug there. I mean, that's one thing you want to remember. But secondly, there's a lactate of 11, with a metformin of 180 grams. 180 grams. Yeah. Is that a lot? Yeah, it's a lot. That's a lot. And with a co-injection of a non-steroidal.
Is that a record?
That is a lot, yeah. I'm not sure if it's a record, but it's a lot.
Yeah, with a co-injection of a non-steroidal that may interfere with the renal excretion.
So that picture, what's that due to? That gas picture?
Metformin.
Most likely
metformin.
So that was obviously the risk assessment at that time. It's just a massive metformin overdose. And then the worst thing about it as well, it's not only massive, but it's also a slow release preparation. The kinetics, who knows, but it might be days before this patient. It's going to be, the rest of the drug injection is probably going to be okay. But that was the main concern in this patient. So they were a little bit hypotensive, and they required some vasoconstriction with noradrenaline. And their gas was slowly getting worse. At this point, Rafe, I might ask you, what would you do?
Well, you know, if it's a slow release ingestion, I might consider doing whole bowel irrigation. Although I've heard, you know, metformin really causes GI distress, especially in severe overdoses. And this person's already hypotensive. I'm not sure if their airway is threatened, but you know, that's something to consider. Is if the blood pressure and the airway are allowing you to do it, and you can decontaminate this patient, I think you'll have an easier course of it if it's a slow release ingestion. Beyond that, I mean, you know, you're out for metformin is hemodialysis or some other renal replacement, just to correct the acidemia and to remove the parent compound as quickly as possible. And this person, they've already got acidemia and a lactic acidosis. So I would probably push to have a nephrologist dialyze this patient.
And I think that was the discussion at the time about getting, I mean, this is so conversation we had between putting them on a filter, obviously easier for ICU, but getting then the nephrologist on board and getting them to come in and approve for dialysis. So I think that was the push in the end, but I think the patient was put on because it's quicker to do, I suppose, without all those kind of formalities with arranging. The patient was put on the filter first. The whole bowel irrigation, I think that was also recommended once they were intubated. They were mildly drowsy, but I think the risk assessment was the patient is slightly hypotensive now. There's going to be a prolonged treatment. Let's intubate them. Let's give them the whole bowel irrigation to see if that will help some of the fragments or any of the decontamination.
She was intubated to be decontaminated.
I think so. I think well, that and the blood pressure wasn't great as well. So I think the risk assessment was she's getting more acidotic. It's going to be a long kind of course of treatment. Let's secure her airway and gain control. I think eventually her pH got even worse and went down to 6.7 at one stage. And she became more hypotensive with increasing lactate and had vasopressin added on top of the noradrenaline or the norepinephrine. And yeah, I think she recovered eventually, but it took a few days to occur. I think she did have intermittent hemodialysis for a period of that time as well, intermittent. But I guess the other thing is you have to be hemodynamically stable enough to sustain the flows of intermittent hemodialysis, and that's one of the cons of it, that you can get quite hypotensive whilst getting the treatment. So that's another thing. Do you guys have, just as a question, do you guys have SLED or PERT? Have you heard of that? kind of a middle ground between renal replacement therapy and intermittent hemodialysis, and some hospitals are doing it.
I've heard of that. We only have dialysis and CVVH. We have something else called Prisma. Unfortunately, I'm not an expert on, you know, all the fine distinctions of those modalities. Even hemoperfusion is very rare. It's hard to find those cartridges and have people that are trained to do it. With SLED, I don't know. I think I've only read about that. I don't think I've actually seen that done.
Yeah. But as you can imagine, I think the main thing was trying to get a lot of this off. I mean, the bicarb was 3 at one point with a pH of 6.8.
Wow.
So I think this patient improved in the end, so I think they did well. But they also got some charcoal with their whole bowel irrigation before they got that. But still a large overdose.
Did they do a bicarb infusion?
I don't think they did. I think they got them on. They may have given a bolus, but I didn't hear any no mention here of a bicarb infusion. I guess the potassium was okay at that time. I guess the worrying thing about
use the bicarb buffer on the dialysis.
Oh yeah, you could do that as well. I'm not sure if they did that, but I'm assuming the dialysis had potentially a bicarb buffer. I guess the other thing with potassium is all the changes is hypokalemia with an infusion. And that's something else you need to be considering. All right. Any other questions on that case?
No. Good case.
No. Did you have another one or not?
I have a short one that I could do, just because it's something that I think flies under our radar a lot, but I think it's worth just talking about every once in a while. And so here we go. 34-year-old woman is brought to the emergency department after being found unresponsive in her bathroom. She took 30 tablets of quetiapine, which is about 12 grams, 400 milligrams each, and the time of ingestion is unknown. Her blood pressure is 78/51. Heart rate is 62. Respirations are 12. Sats are normal. Temperature is normal. On exam, she's arousable to voice, but not following commands. So that's kind of the picture. I don't know if I've painted it well enough, but hypotensive, altered, but arousable after a kind of a massive quetiapine overdose. So I guess that I wanted to present this case is, how much do you worry about quetiapine in general, and how do you risk stratify these patients? And then just to hammer out the fine details, what are the cardiovascular disturbances that you can anticipate, and what are some of the neurological disturbances that have been described with quetiapine? So first, I mean, this is a super common drug for us, and I know just reading some of the Australian literature, it's very common there as well. So what do you want to say, Anselm?
Okay. Maybe I'll see it.
Was that heart rate 62?
Yeah.
It's
Kind of low, right?
It's a bit unusual because usually you get a tachycardia, but there were some cases of XR, large XR preparation. You don't get sinus tachy. I'll fluid load this lady, obviously, to start with. She's quite young, and if it doesn't help, I'll give her some neurage.
Yeah.
You are right, though. It's very unusual to have this level of bradycardia, which makes you think maybe there's a second ingestion, or maybe she took some, a beta blocker, a calcium channel blocker on top of this. Yeah. But as far as we know, it was an isolated quetiapine ingestion.
So with that amount, I would probably consider intubating her if she took that amount. I mean, I guess you're thinking about how long the patient's going to need to recover, which may be another 24, 48 hours. They're hypotensive already. If you intubate her, you probably could give her some charcoal at that point, some of the absorption.
Okay.
Obviously optimize her hemodynamics before you try and do that, but she's maintaining her airway at the moment. We would avoid adrenaline here. I don't know if you've had experience with that, but we've had patients who are hypotensive if you've given adrenaline or epinephrine to the patient.
Oh, really?
Yeah. So actively we say not to give adrenaline. There's a mechanism
You
behind
mean
that.
before fluid resuscitation?
Well, no. Well, fluid resuscitation first, but no adrenaline. We would go. It's a vasodilatory problem. So it, obviously.
The profound alpha blockade in some people makes adrenaline just give you the beta effects, and you drop your blood pressure.
Yeah. So the beta
Oh, wow.
the beta vasodilatation.
Yeah, wow, I didn't think about it that way.
Yeah, so we've had people who have come in brought in by the ambulance on adrenaline infusions, and as soon as you stop the adrenaline infusion, the hypotension resolves. So I've had a few cases like that. So we don't recommend that. It's quite common quetiapine overdose. So we've also had cases which are even more massive in dose ingestion, and there've been some that have been reported in the literature and written up about refractory hypotension responsive to methylene blue once you've chucked everything else at them, such as vasopressin and phenylephrine.
Right, yeah. Which would make
Anyway.
sense if it's an orthostatic or, peripheral hypotension, which is typically what's described with quetiapine, is that it's a peripheral hypotension. It's not a central cardiac depressant, so methylene blue would be an attractive pressor for them.
But I'm assuming this patient did okay with it. What happened?
Well, can I just say, I wouldn't necessarily jump in and intubate. I mean, 12 grams is a lot, and it is an intubatable overdose, but we don't know when she took it. So out of her coma and getting better, and she just needs some fluid and a blood pressure response, or some fluid plus or minus noradrenaline. It all depends on the
Well, to
timeline.
me, yeah, that's why I brought this up. I think that's a very important point, Zeph. We don't know whether she's getting sicker or better. We just have one time point. And it's hard to convey that sometimes, to tell people to reassess this patient. And then, the question becomes, how often do you reassess them? How many resources do you expend with your nursing or with your residents to go back and recheck this patient over and over again, when intubating them would be, okay, then you're done dealing with the airway. So yeah, I think you're absolutely right. She might be getting better, but she might be getting worse. I don't know if there's a good
But
way
she's
to
got an
tell,
airway. She's got an airway and she's breathing, so intubation is not going to change that. And intubation, unless you want to do it to decontaminate for some reason at this particular moment in time, otherwise the resources would be the same. Like if you intubate, then she's got one-on-one nursing in intensive care. So if she's just arrived with those obs, then I'd probably just give her a couple of litres of fluid and then, I don't know, wait an hour or two and see which way we're headed, and she might declare herself.
At 5 grams, you have like a 10% chance of being intubated. At 10 grams of ingestion, you have a 37% chance of being intubated.
Yep.
And at 20 grams, you have a 55% chance of being intubated.
Yeah.
That's a paper by Jeff Isbister. So I thought that was kind of interesting that they just risk stratified according to the amount ingested. Obviously, we don't always have that information. And I don't know if they really looked at sustained release or not. So
Probably not.
sort of 1 in 3 of these 12-gram ingestions will be intubated. So,
but she may have been intubatable, whatever that means, 5 hours ago. But we only found it now. So she's survived.
Right.
And now she's coming out of her coma and she might be getting better. I mean, it's just one point in time.
Yeah. Yeah,
I mean,
I
I think
totally agree. I mean, I've seen a lot of these, and that's why I feel like we see a lot of quetiapine, and we end up getting lucky. At least I end up getting lucky, just because these people do really well, and then every once in a while they present very similarly to everyone else, and then they do poorly, or they ended up getting intubated, suddenly for some reason. So that happened in my ER a few weeks ago, which is what prompted me to present this case. It wasn't this case that I'm presenting, but it was another case that presented very similarly to this. The person was arousable to voice. and then several hours later they ended up getting intubated just because another clinician didn't feel comfortable with how that presentation was. So it just made me rethink, like, okay, how do we actually risk stratify these people other than just reassessing them every half hour?
I don't think you'd be criticised for intubating, but at the same time, you've got to think, what's intubating going to achieve? It's going to achieve maintaining an airway and ventilation. If she's already got that, you know, it's hard to know.
Yeah. Okay, moving on. So would you give this person physostigmine?
At the moment,
have you ever given physostigmine for quetiapine overdose?
Not regularly, but obviously you're worried about the anticholinergic delirium, which could happen. It's not going to happen probably then. It's probably going to be drowsy in the first instance. So potentially you could give it if they're 24 or 48 hours down the track and they're uncontrollably delirious. Usually there's a short half-life on it, but it might be enough to get them into a more lucid mental state so they're not tearing down the place.
I must admit my experience with in terms of the anticholinergic stuff is that there's quite a bit of sedation as well. They're not the anticholinergic patients that are climbing the walls and throwing things around.
Yeah, it sort of depends on why they're altered. You know, if they're altered just because they're hypotensive, that's one thing. If they're altered because of, you know, there's a couple other receptors that Seroquel or quetiapine hits, and only one of those is the antimuscarinic syndrome. There's also an antihistaminic syndrome that just causes pure sedation. And so it kind of depends on, you know, why you think that they're altered and whether the antimuscarinic syndrome comes to the forefront of your diagnosis. Then I think it's worth doing physostigmine. I mean, I was shocked. I've never even thought about doing physostigmine for a Seroquel overdose, but apparently it's a thing. The Minnesota group has been publishing a couple of papers about this. And I think their largest case series was like a dozen patients where they said, you know, they gave physostigmine, it was safe, and it prevented intubation in a lot of patients.
But it woke them up.
Do what?
Did it wake them up?
Yeah, it woke them up. And some of them were like in day 3 of their hospitalization. And the person was just having a delirious, they were just having waxing and waning delirium, and they diagnosed anticholinergic syndrome related to physostigmine and gave them, related to quetiapine, gave them physostigmine and woke them up.
An emergence delirium is one thing, but this person that you've just presented was, you know, semi-comatose. That's a different.
Right. No, totally. And they're relatively bradycardic. So 2 good reasons that I would not give them physostigmine. But, you know, now that it's out there in the literature, you know, I think clinicians may read a paper like that and say, oh, physostigmine is the antidote for quetiapine, which is sort of, you know, I think an inappropriate conclusion to draw.
Yeah.
Of course, there was that case report a few years ago where they used intralipid and the patient woke up from quetiapine.
I've seen that. Yeah, I have. The other thing is another thing that really puzzles me about quetiapine is how much do we have to worry about the electrocardiogram? You know, we know it causes long QT time. It causes torsades in only a handful of patients, but it seems to be no more common than any other overdose. I can't find a single case report of it causing a wide QRS related to sodium channel blockade.
Wow.
So, you know, is this really a cardiotoxin, or is it just you know, going to cause some hypotension that's responsive to fluids?
I don't think there has been a report on torsades, has it, with quetiapine? Never seen one.
I've seen there's a I don't know, there is literature, like there's one case series of like 17 patients that, you know, had long QT time and then developed torsades. I'll try to find it for you. Yeah. But nonetheless, I mean, this is what we recommend to people, you know, every time we get a quetiapine overdose is, you know, watch the QT time and watch out for torsades.
Yeah, and the tachycardia is going to be protective for the development of torsades anyway, so most of these patients are tachycardic. With the QRS, there was one case I remember looking at a long time ago because someone mentioned may cause sodium channel blockade, but I wasn't really convinced that it did because they also took some tricyclics, and it's hard to differentiate between that case. So certainly it's not a very common thing if it does, but I don't, in my experience, it doesn't really cause chloride widening.
Should we be calling it QT, Ivan?
Right. No, I think that's probably why the association exists.
Okay, I think that's all the cases and time we had raised today. Thanks for coming.
Okay, yeah, thank you guys.
I'll send out this video and the others can have a look at it. But thanks again, and we will catch you next time.
Are you going to Europe, Race?